Good afternoon and welcome to the Caregiver Teleconnection. My name is Glenda Rogers and I'm going to be your facilitator for today's call. Today we have with us Dr. Natalee Oliver, and she's going to be talking to us about mental health and aging. But before she gets started, we have a special guest, Dr. Carol White. Carol is a professor at UT Health Science San Antonio, the School of Nursing. She was the director of the Caring for the Caregiver program until her partial retirement. She continues to conduct research to optimize outcomes among family caregivers of persons living with dementia. And she's calling in today or Zooming in today from Montreal, Canada. Carol, thank you for being with us. We're anxious to hear about the programs you have to share.
Oh, I'm really happy to be here. Thank you so much to you, Glenda, and to Dr. Oliver for letting me take a few minutes just to talk about some of the research. We've worked very closely with the WellMed Charitable Foundations. They were really forerunners for us in starting our program at UT Health, Caring for the Caregiver. And I put our website in the chat. It's utcaregivers.org. We have an integrated service and research program, but what I really want to talk about is a couple of our research programs that we're conducting right now and looking for caregivers to help us with these programs. One is a simple survey that caregivers complete to talk about what things are problematic for them, what things do they find bothersome in the caregiving role, and then to rate the impact of those. And then there's kind of a little fun game at the end where they're given 20 tokens and they can decide how many tokens would they want to spend if they could change that. And the reason this measure is so important is we don't have a good measure that helps us when there's a treatment for Alzheimer's or other forms of dementia as the disease is progressing. Sometimes the changes are very small. What we want to know is what makes a difference for the family caregiver. And so this measure is being developed to look at that. And so we need your help in developing this measure. So I've put in the chat, you can find out about this project on our website, utcaregivers.org, under the research. It's called the CARED survey, which is it's a preference-based or developing a measure for family caregivers. I also put the name and contact information for our research assistant, Louis in the chat. And this survey is really doing an eligibility survey that takes about 1 or 2 minutes to do, and then a second survey if you're eligible that takes about 15 minutes to do. And then to thank you for this, we have a $10 Walmart gift card. So I encourage you to look at that because we do need your help to develop this survey. The second research project that you had mentioned, Glenda, a little bit earlier, is Juntos Together. And it's an intervention study designed specifically for Latino family caregivers. It's a 6-week intervention where we each week meet on Zoom for an hour and a half and provide you with information about the different aspects of giving care. It complements actually the stress busters that WellMed offers. That's more about caring for yourself. Juntos Together has some information about caring for yourself there, but it's more how do you care for your family members? So we talk about home safety, managing medications, communication, dealing with behavioral challenges, just to name a few. So if you're interested in learning more about that project as well, go to our website. You'll see the content, or you'll see the information about the project, but also you can contact again our research assistant, Louis. Thank you so much, Glenda. I think that's all I'll say.
Thank you, Carol, very much for the research you're doing. Boy, do we need research in this area. So thank you so much. And everybody, you can see the information in the chat box, write it down and participate. Doesn't sound like there's a lot of time involved, Carol. So glad about that. Okay, Natalee, you want to put up your presentation and tell people a little bit about yourself before you get started?
Yes, ma'am. And Carol, I'm so glad that you are here today. And I am an advocate for Alzheimer's and dementia. And my aging parents live with us, and my dad he's in the middle stages. And so I definitely will share that with my mom to fill out as well. So thank you for all that you do.
Great.
Like
Thank
Linda
you so
said,
much, Natalie.
sure. Research is very important. It's not my strength. Somehow I got through it in college. But I really appreciate those that do the research. So here is, yes, we're going to talk about mental health and aging. And, you know, those of us in mental health, we have to put all the letters, or not mental health, those of us in higher ed have to put all the letters behind our names. It's, I don't know if it's a competition or something to make us feel better, but that has my email if you do want to get in contact with me. I went ahead and put this up, especially for today's session. I have a background, I'm a clinical social worker, and so I have provided individual and group therapy, and I only work with adults, primarily older adults, and I have worked with substance abuse, mental health. I have worked with those that were mandated by the court and those that were voluntary. And then you can see at the bottom just the different types of locations. And so my passion is aging and mental health, and also Alzheimer's disease. So very glad that you're here. I told Glenda that I will share this PowerPoint. There's a lot of information, so it may seem I'm going a little fast, but I just want to make sure you get it. But you can also have the PowerPoint with all of the links as well. So if you come to any of my presentations, I do like numbers, and I am not to memorize the numbers, but I always tell caregivers and my students that it's the impact. What do these numbers mean? That's the part that I'm hoping you'll take away with you. And so we'll start with how America's aging. We know right now, the aging population, meaning 65 and over, is about 17%. And we know by 2030, which we know how time flies as we get older, is just down the road, and how that's going to increase to 73 million older adults, which equates to 1 in 5. And so what I tell people is that, especially students as well, is that you may not plan to work with older adults, but you will indirectly, if not directly, be impacted because they may be living with their grandchildren, or they have younger family members taking care of them. And then I just put up what the life expectancy is currently for those of you that are interested as well. And that means when you're born, how long are you expected to live? And right now it's 76 years. And then of course it breaks down that women are expected to live longer than men. Another thing I wanted to start with was a definition. So according to the World Health Organization, this is how they define health. Health is a state of complete physical, mental, and social well-being. So this just again reiterates the importance of that mental health is just as important as physical health. And if you look at the research, you can see that they do impact each other and both play a major role in the lives of our older adults. I wanted to start this off with looking at chronic diseases. So before we get into mental health, it's important, again, I know I'll have lots of numbers and words, but really it's just getting the main information, which is those that are age 65 and over, 80% are living with a chronic disease. Chronic meaning long-term. Sometimes you'll hear the word acute, and that's short-term. And so many older adults are living with these complex health issues, and it impacts the quality of their life. So this is a picture from the National Council on Aging that just gives you a really great visual of the top chronic conditions that people age 65 and over are living with. Again, back to that 80%, that's 1 in 5 that have at least one. And if you look to the right top, almost 70% have at least 2. And these are the ones that we know of, the reported ones. So you can see the top chronic conditions on there that do affect the quality of life. And it even includes depression on there for older adults. Lots of words, but if you'll just focus on what I'm saying, which here is, I wanted to show you the top mental health diagnoses in the United States for adults. At the top of the picture, you'll see 1 in 5 US adults experience a mental illness each year, 1 in 5, and that's currently. And what we're going to focus on today is anxiety and depression. You can see anxiety is the #1 mental health diagnosis for adults in the US. And then we have major depressive disorder, which we're going to break that down, is the second one. But many of you on here are caregivers, so I wanted to add this in there as well. 1 in 6 Americans are currently taking care of someone over age 50. I'm sure if we were to have you raise your hands right now, many of you are in that situation. And so I thought this was interesting, and I'm sure many of you can relate to this. Many caregivers of adults with mental or emotional health needs spend at least 32 hours a week providing unpaid care. That is a full-time job. And so what's funny is when I practiced this presentation with my mother to make sure I'm saying things that are relatable. And she said, well, you need to put on there, plus caregivers are taking care of themselves, which is so important to address as well. We are talking about our aging loved ones with mental health, but caregivers, many of us have mental health issues as well. So there are many myths that are out there about mental health as it relates to older adults. The #1 myth I hear all the time is that dementia is a normal part of aging. It is not. Another one, that depression is a normal part of aging. Clinical depression, being diagnosed with depression, is not a normal part of aging. Another myth out there is that older adults don't have addiction issues. We know that's untrue. We know that alcohol and then opiates and other medications are also being misused as well. Another one we hear a lot is older adults don't respond to treatment, or they're set in their ways and they don't want to change. That's another myth that is out there. We know that research shows that at least 80% of older adults will respond to treatment. Another myth is that older adults have grown out of their anxieties, which we know from the numbers, it being the #1 mental health, that's simply not true. And then a lot of times we hear, oh, they're just being stubborn, they're different behaviors. Well, we need to look into those behaviors. Is it a medical issue? Is it a physical issue? Is it a mental health issue? And then one that people automatically think is that older adults are all the same, and they're just as different and have a variety as any age. Another thing I wanted to briefly bring up is that we have the stigma. It's still big out there about mental health. Like, I'm 49, so especially with my generation and older, a lot of times people won't talk about their mental health. Or I know when I was younger, it was people just thought, oh, get over it. You have a good life. Why do you feel this way? And so what I wanted to point out here is that older adults not only are dealing with age discrimination, which you can see that in the media and such, they're also dealing with the stigma of mental health. So that's why things like today are so important. And I'm just really glad that you're here today. And the reality is, most older adults, they may have some changes in their cognition, which cognition is thinking, but they're generally mild. That's the reality. And older adults are just as capable of learning new information as younger adults. Now, sometimes the speed at which they may learn or may communicate may be a little slower in reaction times, but their capabilities are still there. And then I also wanted to point out personality traits generally remain the same. And I remember this professor I had when I was getting my gerontology degree that said, grumpy old men were probably grumpy younger men. And that really stuck with me because, again, your personality traits are pretty stagnant across the lifespan. For those that are visual, I wanted to put up pictures of what depression can, to help you understand what it feels like. I found these pictures. I don't remember where I found them on the internet. It's been a couple of years, but they really stuck out to me. If you look at the one on the left, you see all these different emotions, these words that come into the mind of someone with depression. Like guilt is up there at the top. Stupid, ugly. You just see all of these words, and those are a lot of the feelings that someone with depression can feel. And then if you look at the right, you see where someone's sitting alone and it gets darker closer to them. And many people that are living with depression just feel alone. Some of that can be, they don't even know they know the symptoms that they have depression because of the stigma that's associated with it. So older adults do struggle with many of the same stressors that young adults do, but there are other extenuating circumstances. Going back to those chronic conditions that we talked about that they're living with. So heart conditions, diabetes, other things that they're having to live with on top of mental health. Decreased in functional ability. You'll hear these terms, ADLs, activities of daily living. Those are the physical things like dressing, bathing, toileting, transferring. Then you'll hear of IADLs, instrumental activities of daily living. That's balancing a checkbook, writing a grocery list, those kinds of things. And so because of reduced mobility or chronic pain, a lot of times older adults are not able to do some of those functional things. And so that can bring about depression. Another risk factor is financial issues. If they've lost a spouse, they don't have that income, or they've retired. Another thing that is not talked about, which could have its own session, is talking about elder abuse. It does happen, and that can be financial exploitation. That can be physical abuse. And yes, sexual abuse does happen of older adults, but it can also be neglect. All of those can lead to depression as well. Another thing is caregiver stress. So many older adults not only are taking care of an older loved one with mental health issues, but they are a caregiver as well. And then lack of physical activity, whether that's due to mobility issues or because of lack of time or energy, that's another reason. And then we have loneliness, and that's at the top of the list for depression as well. Many people have died off, many of them are living alone, not as social, so that can definitely lead to loneliness. There are different types of depression. We're not going to go into detail today, but some basic things that I think would be good to understand are, a lot of times you'll hear the word mood disorder. Depression is a mood disorder. Depression can affect how we feel. And that in turn can affect how we act and how we think about things. And so the different types, the one you hear about a lot is major depressive disorder. And there are many criteria that have to be met, but basically these symptoms are lasting at least 2 weeks, and they are interfering with a person's ability to perform daily tasks. And so all of us have times when we're down, but we're talking about things that really impact daily life. Another one we have is persistent depressive disorder. You might have heard of it. It used to be called dysthymia. And I always think about, if you kind of picture someone with a cloud just hanging over them, they're still functioning, they're still going on, but they're just having this low-grade depression. And so that's another one that is common in the adult population. And then you have others that can be substance or medication-induced depression, or depression due to medical conditions. For instance, those with heart disease have higher rates of depression as well. Some risk factors. So sometimes there's just changes, chemical changes happening in the brain that can cause depression. Sometimes there's a major life event, someone getting diagnosed with cancer or losing a loved one. But the thing that's really important with depression or anxiety or any mental health really is that it can happen for no apparent reason. And so you can have clients that say, I've got a really good life. I don't know why I'm feeling these things. And so it is a medical condition, just like we would say diabetes. And so some other things that are related to depression as it relates to older adults are, is there a family history? We know genetics can play a role. Again, back to that caregiver stress. If someone's having sleep issues, we know sleep can affect every area in life. And that would be another good caregiver training to do on WellMed, is just the importance of sleep as well. We also have those functional limitations that we talked about earlier. Just if you think about it, someone that used to be able to get up and go, if they can't do those physical things and they're relying on someone else to help with some of those intimate tasks, of course that can lead to depression. Here are some of the actual symptoms. So one of the ones that people don't think about is just apathy. So someone that just really doesn't care, they're kind of just going through life but not really having many feelings. That can be a symptom of depression in an older adult. That persistent sadness. Another common one that people don't think about is irritability, and that especially comes out in men. So if you're seeing where they're having this increased irritability and that's not normal, that could be a symptom of depression as well. Fatigue and low energy. So just I'm always tired and just no energy really to do anything can be a symptom. A sense of hopelessness, just not really feeling hopeful, can lead to depression. Another major one that a lot of people start to notice is this loss of interest in activities that someone once enjoyed. So if your older loved one always loved getting together with their friends and playing cards or talking on the phone, and they're not just doing those things that they used to love, that is a big risk factor for depression. Something else is trouble concentrating. Even some memory loss can be due to depression and not dementia. And so there are many different symptoms in older adults. Insomnia, not being able to sleep, or sometimes people oversleep, thinking, I don't want to deal with how I'm feeling, so I can escape it and just go to sleep. Appetites can change, where there might be this emotional eating, where I'm going to eat to fill that void and that depression. Or some people that are depressed have no appetite. Another common one that people don't think about a lot is slower speech or slower movement. Now, we're not talking about if they have other medical conditions, but if you're just noticing someone starting to talk softer and slower, that can be one of the symptoms of depression. Digestive problems, and then sometimes they'll go to the doctor and they'll have these physical complaints, but they can't really locate what it is. And so that can be signs of depression as well. And then reoccurring thoughts of death. So all of these symptoms are important, but the two in orange, a sense of hopelessness or reoccurring thoughts of death, which could be, it's okay, I'd be fine if I went to sleep and didn't wake up. That's passive suicidal ideation to all the way of, I don't want to be here anymore. If they're expressing the ones in orange, you definitely need to get help today for them. Those are serious things to take serious. And then I mentioned this earlier too, that dementia and also Alzheimer's, it's common to have depression as well. And again, if you think about dementia and Alzheimer's in the early stages, when you're still figuring out what's going on, depression can be common. And then a lot of those symptoms can look the same. So you'll see in the literature where that depression is called pseudo-dementia, meaning that it looks like dementia, but it's actually depression in older adults. So it's always important to get to the doctor, to get medical, physical exams, and to get evaluated. So now we're going to move to anxiety. And again, some visuals to help people understand. If you look to the left, this lady is carrying this all on her shoulders. And that's what anxiety can feel like. And some of you that experience it can relate to these. You can see at the top where they say, I'm not good enough. And just all of those feelings that can happen to where you just feel like the whole weight of the world is on your shoulders. And I love the picture on the right. It's a little chaotic, but that's how anxiety can feel when you're having that rumination, those thoughts over and over, and just restlessness. There's just lots of things you could feel. So when someone has anxiety, this can help you picture what they're going through when they're sharing it with you. So anxiety, again, it's the #1 mental health for adults. And there are many types. We're just going to touch on a few of them. There's what we call generalized anxiety. And this is this chronic, exaggerated worrying about everyday life, where it's consuming many hours of the day. And it makes it hard to concentrate and do other tasks. It's more common in women than men. and it often co-occurs, meaning that it also happens when someone has major depression. And so it's very common to have both of these together. Another one type of anxiety is social anxiety disorder. And this is this intense, irrational fear and worry about being humiliated in front of others. And so it's not just the general nervousness of if you're giving a speech or doing something. This is, again, that irrational worry of humiliation. This can get to where people start to isolate themselves because their fear that others are judging them. This is equally common in men and women. Then we have what's called panic disorder. This is the sudden feeling of terror, and sometimes it happens without warning. And if people are not aware of mental health, they're going to think that this might be a heart attack because you're having some of the same physical symptoms as a heart attack. And so this is also more common in women than men. And then another type of anxiety are these phobias. You hear of claustrophobia, or maybe there's a phobia of being in an elevator. This just, again, it gets to, it's not just a fear, but it's this irrational fear where you start to avoid things because you're fear of panicking. And there's can be many different triggers, many different things that get you to feeling those things. And so, again, this is more common in women than men as well. So as far as older adults, we know that between 3 and 14% of older adults meet the criteria to be diagnosed with anxiety. So not everyone, again, back to the myths and the stigma, not everyone will get help. And so, but we know that they are meeting the criteria for it. As far as anxiety in older adults, generalized anxiety disorder, that's the first one I just talked about on the previous slide. This is believed to be the most common type of anxiety in older adults. And again, it's just that constant worrying. It's that fear of the worst in every situation, and it's unfounded. There's no proof for that worry. And if, always on edge. And this next one's real important. So a lot of people with anxiety, they may understand that their nervousness is excessive and unrealistic, but they can't control it. So in their mind, they know, I know this is not going to happen, but I can't help the way I feel. And again, it gets to be more common in older women than men. Now, there are many different symptoms for anxiety. There are mental and behavioral, and then there are physical. So some of the mental and behavioral are these obsessive thoughts. It's called rumination. Sometimes you might lay in bed and just think of things over and over and over, replaying it. And you can't get it out of your head. You might react to something way out of line, not appropriate to what actually happened. This restlessness, they just can't relax. Again, trouble with memory or not able to focus because of anxiety. We have insomnia where you can't sleep. And then some of you, I know I've had these sometimes when I'm anxious about something. You have nightmares. I have the same nightmare that I'll have when I'm anxious about something, where I'm on a college campus and I can't find the building of where I'm trying to go. And so sometimes you'll have nightmares. That can be a sign of anxiety as well. And then this uncontrollable feeling of panic, fear, or apprehension. And then people with anxiety may just have these ritualistics where they might repeatedly do something. So they might ask you things over and over. So you might think, oh my gosh, my loved one's having memory issues, when really there's just anxiety and they're needing that reassurance about something. And then there's physical symptoms of anxiety that can be dry mouth, racing heart, trembling, hot flashes, although we all know as women, hot flashes can mean lots of things. Headaches, frequent urination, nausea, tense muscles. I know, like, my tension all builds right here in my neck and my shoulders. And then cold or sweaty hands. So these are just some of the symptoms, the physical symptoms of anxiety. And when it comes to what's causing anxiety, we know that some of it is genetics, that it runs in families. But the one I really want to focus on today is the environment. This is so important for us to realize with our older loved ones that we're caring for. They may have had a traumatic event, such as the abuse that we talked about earlier, death of a loved one, violence, a prolonged illness. All of these can lead to anxiety. And so we really need to think about that when our loved one who was married for 65 years loses someone. So again, some of the risk factors for older adults is this limited mobility. And another one is this loss of independence. We know that older adults, once they fall, the odds of them falling again increase. So some of them have so much anxiety about falling again, then they don't drink as much because they don't want to go to the bathroom. They don't move as much. And so all of that can be due to anxiety, sleep disturbances, chronic health conditions like we talked about. Side effects of medication is another one people don't always think about, but that can cause anxiety as well. And then one that I forgot to put on here is caffeine. If you're feeling really anxious, don't drink caffeine. That can increase your anxiety as well. And then trauma from childhood, and something I learned from a training I went to a couple of months ago, which was really important, was we know that Alzheimer's is people are progressively going back in time, generally. And so sometimes those with Alzheimer's may re-experience traumatic childhood events because they're going back in time. And so if we're dealing with a loved one with Alzheimer's and dementia, that could be another reason for the anxiety. Love this visual because, as you've seen with all of the risk factors and the symptoms that I shared with you, you can see the overlap here. Then that's why it talked about generalized anxiety disorder and major depressive disorder are common. They a lot of times co-occur, happening together. You can see the common symptoms here. And again, that's why it's so important to go to the doctor and get an assessment. I was thinking I wanted to touch on these briefly, and that is that sometimes people have seasonal affective disorder. This is a type of depression that happens usually in the winter months when the days are shorter, the sun's not out as much, the weather's more dreary. And so it's where they're having some of the same symptoms as major depressive disorder, but it's only certain times of the year. And so that's just another type of depression that's out there. And then I also wanted to bring up adjustment disorders. So a lot of times these are stress related, excuse me. So if you're noticing these symptoms within 3 months of an event, usually it lasts 3 to 6 months, but it can be longer. But one example is if your older loved one is moving into an assisted living. That's a huge adjustment. And so this may be something that they just have to work through just for that. It's not a long-term thing, but something they may need help with. So we're going to talk about treatments and interventions. And the two we're going to talk about is psychotherapy and medication. So you'll hear the terms psychotherapy, talk therapy, therapy, counseling. All of these are when it's talking out issues. And so you can be seen by a psychologist, a licensed clinical social worker, a licensed professional counselor. There's many mental health professionals that are out there that can help with the talk therapy. There are many types of therapy. People specialize, but one of the ones that has tons of research and is used is called cognitive behavioral therapy. And I want to show this because a lot of people are nervous before they go to therapy. They don't know what to expect. So it's important to have a basic understanding. So a lot of times we have these automatic thoughts and they start to affect our emotions and our behaviors. We have them all the time, like, especially if we're living with depression or anxiety of, I'm worthless, I'm old, I can't even go to the bathroom by myself. Why would anyone love me? So we have these automatic thoughts that come in. And so when you go to therapy, you can talk about becoming aware of these thoughts, how they impact you, and how to change those thoughts. You can learn problem-solving strategies. You can learn effective ways of communicating. So things to do instead of yelling at someone or when we get mad, we can learn effective ways, and you have a safe place to practice these communication skills. You'll also learn relaxation techniques. There's what we call progressive muscle relaxation, which I do all the time, which is amazing. Deep breathing can help with anxiety and depression as well. And so really going to talk therapy is having someone to emotionally support you. And I always explain this to people. I'm not your family member. I'm not your friend or socialize with you. So I can be objective and I can tell you, here's what I'm seeing. Here's what the literature says are the best ways to approach this. Another thing that professionals can do is dig into and notice and assess for harm. And so are some people having thoughts of hurting themselves? And so they can recognize these warning signs and go over coping strategies for that. We also have medications that can help with depression and anxiety as well. Now, those can only be prescribed by a psychiatrist, a mental health nurse practitioner, but something else that's very common is primary care physicians. You have this great relationship with your clients, your patients, and they are well-versed and well-educated, many of them, and very comfortable with diagnosing and giving medications. And I have provided a website here where you can get the latest warnings, the side effects, and newly approved medications, if that interests you as well. So I'm going to briefly go over this. I want to make sure we have time to talk at the end. But with antidepressants, so that's medications for depressions, a lot of times the common ones are the SSRIs. And so you've probably heard of Prozac, Lexapro. There are just some common ones out there that have had a lot of research on them. And the good thing about those common antidepressants, they can help with a wide variety of symptoms for depression and anxiety. Because remember, some of those symptoms overlap, like we saw on that visual. And a lot of these medications have fewer side effects than some of the others. And so that's why a lot of times you're prescribed an antidepressant for depression and or anxiety. Something else that I really try to educate caregivers and older adults taking the medications, they take time to work. It is not take a med and a miracle works. They take time to get into your system. It can be up to 8 weeks. And it's not a cure-all for everything. A lot of times I tell patients, it just helps take the edge. It helps with some of the symptoms, but we still have to work at any depression symptoms that we're having. And then it's always important to follow what your healthcare provider, the directions are. Never just stop a medication. And you'll find any of you that have any experience with mental health, a lot of people, when they start feeling better, they stop taking their medicines. And so it's this fallacy of, oh, I feel better, I should stop, when they forget it's the medicine that has made them feel better. And then, of course, a lot of times with the older adults, just because of how their bodies absorb the drug, it's going to be lower doses. So here you're just seeing with anti-anxiety medications, you're going to have some of those SSRIs like we talked about for depression, but you also may have some benzodiazepines, or sometimes they're called benzos, like Xanax and such. And those can be used, we call it PRN, which means as needed. The person with anxiety is not taking this continually every day, but they're just taking it as needed for like if they're having a panic attack. And then another one is called buspirone or Buspar. It's funny, the research on this, it's kind of down the middle. Some people really love it. It really helps with anxiety, and about half say, this doesn't do anything for me. So it's really just individual. And so we're having to see what works with you and what doesn't. And so that leads me to this, that treatment, the best treatment that the literature says is to have the medication and the psychotherapy, the talk therapy. But another thing is that it's very individual. So it may take trying different medications at different levels. It's not a quick fix. It's something that you have to work at to find the right balance. I also want to talk about this, though. there are things that people can do that do not require medication, that do not require therapy, or that can be done to supplement medication and therapy. And this is sleep. Again, we could have a whole session on the importance of sleep. Sleep affects everything. Sleep affects our mood. It affects decisions we make. You can think about times you didn't get sleep and maybe how short you were with others. I know I can. And so sleep is so important. We also know staying active and exercising is so important for our mental health. We release these endorphins, these feel-good chemicals. And some literature shows that depending on how much exercise we do, it can take the place of an antidepressant. But the thing to remember with our older loved ones is all of us have different levels of exercise. So even if you give them a can of peas or corn to do arm exercises during commercials, that's some kind of exercise. And that's going to help increase their self-esteem as well. Also, we know socialization, again, isolation and loneliness is top for depression. And then eating right, that goes along with sleep. If we're not eating good, healthy food to give us energy, and then that can really make our depression and anxiety get even worse. So what can you as caregivers do to help your older loved one with mental health? You can educate yourself. So coming to presentations like today with WellMed and just getting a good basic understanding of these different issues that older adults are going through. Also, just re-emphasizing that mental health is just as important as physical health. Going back to that definition of what health is, it's our mental health and our physical. Always being respectful and sensitive when discussing mental health. Remember, a lot of our older adults were brought up with just get over it, or if you have mental health, you're insane. And so just being really sensitive with our word choice when we're talking to them directly. If you're comfortable, be open with sharing about your own mental health struggles or what you do to take care of your mental health. That helps normalize and just kind of validate what they're going through. Also, keep a journal, write down symptoms and things, observations that you've made. So when you're talking to them, again, with respect, you're sharing with them, here's what I'm seeing, and here's some examples. We need to always listen and be patient. We can also assist them in getting the help they need, researching things, helping with transportation, making sure that they are taking their medication. We can provide literature to them, giving them handouts, printing some of the stuff from today you can share with them. Because if you just tell them, they may say, you're my adult child, I don't want to listen to you. But if you show them the research and the literature, they might be more inclined to listen. And then another myth we have is that we shouldn't talk about suicide, that for some reason we think that will put the idea in their head. That's not true. We need to talk about it without getting over emotional, being factual. And if they're showing that hopelessness or saying things like, man, I wish I could go to sleep and not wake up, we need to talk about those things with them. And then we need to encourage that self-care, which we talked about, the eating, the sleeping, the exercise, and socialization. Lots of information here, but what I want you to see on the left side, places you can look to get help for talk therapy and or medication. Something else on the right, anywhere in the United States, if someone is suicidal, you can dial 988, you can text, you can go online, and you can talk to someone right then. There's also a veterans crisis line. This you can call, you can text, you can chat online as well. If you click on these links, it'll take it to them. Then I also want to share with you about, I know in Texas, you can call 211 to find out about the local services for older adults, but every state has what we call Area Agency on Aging. And I actually did counseling for them. So they contract and they pay me to provide counseling to older adults, and older adults don't have to pay anything. So Google Area Agency of Aging where you live and see if they have that service. So as the professor and me, I always like to summarize, what did we talk about today? So we talked about that many older adults are living with chronic conditions and that this can definitely affect their mental health. We talked about health, including physical and mental health. We talked about the many myths about aging and mental health. We talked about discrimination for older adults and the stigma that accompanies it that keeps them from getting help. We talked about anxiety and depression being the leading mental health disorders for older adults and adults in general. We covered a lot of symptoms and risk factors, what it looks like in older adults. Then we touched on the treatments that can be out there, the talk therapy and the medications. We also talked about the importance of the self-care and then how you can support a loved one. And then at the end, we talked about how to get these services. So here is time for questions or comments. This is my email. I have no problem with you emailing me, and it is no liver in Oliver at McLennan. I know, mclennan.edu. You can email me, but in the subject, if you'll just put, I attended one of your WellMed. And then I honestly, again, I am non-biased. I'm going to give you honest feedback. And so if you text me or call me, I don't mind sharing information. If you call, leave a message, we know because of all the marketing calls, but I don't mind just giving you at least a direction that you can go. So that's it in a nutshell, lots of information. Again, Glenda can share this PowerPoint with you. And now we can open it up for anyone. I'm going to stop share.
I had never noticed your email address before. As many times as I have emailed you, I have never noticed that. That's quite funny. Easy to remember.
That's
okay.
right.
If you have a question or a comment, you're welcome to unmute your microphone right now, and I'll call on you by name. If you have dialed in, you can press *6 on your telephone. That will unmute it, and I will call on you by your area code. I think most everybody has zoomed in today. So do you have a question or comment, maybe something that you've had an experience with mental health issues and caregiving that you might want to share with us? We always learn so much from caregivers as they're with us on these sessions.
While we're waiting, I wanted to share one last thing that I forgot to mention, or I might have briefly touched on it. Some people don't know how to talk to someone about mental health because it's very sensitive. And so we know, especially the older generation, really respect their primary care doctors.
Mm-hmm.
And so if you just call them and talk to them or their nurse ahead of time, here's some symptoms I'm seeing. Can you address this? Can you bring this up? There's something obviously about hearing from a professional, especially an MD, versus the family member. And so talking to them and just getting them on board what's going on helps as well.
Right. Minerva is joining us, and she says, can someone who is diagnosed with persistent depressive disorder or other eventually go to lower doses of their medication after time? Is that something that happens?
Yes, for sure. That's the thing about, you can get treated for anxiety and depression. Some people will live with it always. Some people will get treated. But yes, a lot of times with medications, you'll start with a low dose and then it may increase. Maybe you're having that adjustment disorder, or you've had a loss, or you're going through grief and bereavement, which we didn't even have time to mention today. But sometimes you might need that higher dose. But a lot of times it's just for a certain stage in life or a certain period in time. And so you can lower. And so but it's always something to talk to your professional about. And you need to do it they call it titrating down, because if you just stop taking your medicine, you're going to have a lot of side effects. And so, yes, you might get to where you get the therapy, the talk therapy, you learn those skills. You don't need therapy anymore. You might learn with the medications, lower the dosage, and eventually get off of them. I mean, for example, when I'm remarried, but when I went through my divorce, I went to a counselor, and I also was on medication. So that was for that time period of what was going on. And so I had to work through that, and the medicine helped because my anxiety and depression was out of control. And so, yes, they can be for a time period, and you can definitely lower medication and maybe get off of it. Good question.
Yeah. Did you see in your research, or do you know right off the bat, is the stigma about mental health counseling, is it generational, and is it getting better where people are not afraid to seek help as they were in previous generations?
Yes,
Instead of
ma'am.
pull up your bootstraps and go on, Yeah.
Definitely. Especially the older generations, it was, don't share our problems outside of the family. Don't talk about it. You're crazy. What do you have things to be upset about? But it's interesting as a professor, I have students come up to me all the time, oh yeah, I have bipolar, or I was in the mental hospital this past weekend, so I couldn't get my homework done. It is so talked about now. The younger generations have no problem talking about it, but the older ones still have this. I mean, even I growing up, like I said, I'm 49, I'm a Gen Xer, and growing up, that stigma was so strong that when I was going through my divorce, I didn't even want to get help. And it was my primary care physician. I remember crying to her and saying, I don't know why I'm having all these symptoms. She said, that's depression. And so that's way back in the day before I knew anything about mental health. And so, yes, it is definitely a generational thing, but we are, with the Me Too movement and all the different movements that are out there, people are talking about things a lot more.
That is good news. That is really
Yes.
good news for sure.
Yes, ma'am.
We have about 7 minutes left. Anybody have something that they want to talk about in relationship to aging and mental health? The chat box is open, and you can put what you would like to ask or what you'd like to comment on in the chat box also.
And I also didn't know, we definitely can answer those, but if Carol had anything else, any last parting words about, if there's anything else you wanted to share, not to put you on the spot, if there was anything else you wanted to share, since we have some extra time as well.
Definitely.
Thanks. So, Dr. Oliver, except to say how much I enjoyed your presentation and how much I learned from it. But again, I think just to reiterate what you had said, that research is so important, and the importance of really being able to have people participate so that we can get the research done.
Absolutely.
Yes. Yes.
Absolutely.
And I talk about a lot in the dementia trainings that there are so many benefits of participating. You get access to professionals that you would not have any access to before. You get access to information, professionals, and there's so many benefits. You're part of this changing and helping solve this huge issue. So it's definitely important to be a part of those studies if able.
Right. And we are including the information that Carol, Dr. White, put in the chat box for you. So that will be coming out in the follow-up email that will be coming to you in a few days if you register for the call. It will have a little survey to give us feedback on what you thought of the session. We would always like to hear from you if you have a topic that you would like us to cover. We do repeat some topics because having a different presenter gives you a different slant on things, but we always are looking for new topics to present on the Caregiver Teleconnection. While you're thinking about that, let me just tell you what's coming up. Let's see, next Tuesday, I'll be back with you with Evelyn Greb, and she's going to be talking about isolation and caregiving. We know that isolation is just absolutely detrimental to caregivers, and you kind of slip into it over time before you even know it. And so I'm glad that Evelyn's doing this presentation. And then next Thursday, I'll be back again. Dr. Jamie Heisman, who's with us every month, he's going to be talking about, can we honestly say that we love ourselves? Well, that's a good one. We may be saying it, but do we really feel it? Let's see. Thank you.
I'll share.
Yeah. Okay, go right ahead.
I have to say, I love your presentation. And when you were going through describing the different types and the different symptoms, I was like, yep. No. So I was like, I'm being attacked in this whole presentation.
When we have what's called a DSM, diagnostical statistical manual that we use that have all the criteria to diagnose. And I remember when I first started reading through that, I was like, Oh, I have that. Oh, I have that. Oh, I have that. Same thing with giving like symptoms of dementia. I was like, oh, I have that. I have that. So yeah, but it is common, and it's the main thing when we're thinking about mental health is all of us have anxiety at times. All of us get sad at times, but is it impacting your daily life? And when it's impacting your ability to function, that is definitely when we need to start getting the professional help. But thank you for sharing that.
Thank you, Minerva. Anyone else? Well, you just have a couple of minutes left, and if y'all know me, I'm not going to hold you on this session if nobody has any questions or comments. So our time is valuable, and as caregivers, it's really valuable. Yes, Nancy?
I am a facilitator for a dementia support group for my county. And I think I just want to make sure that caregivers go to support groups, because the depression and all the things you've been talking about can be prevalent in the person with the illness as well as the caregiver. And when you're in a group, you can experience being with others who are going through the same thing. And you can hear about what they did that maybe helped, and you can share and get support at the same time.
Definitely. I'm so glad
Wonderful,
you brought that
Nancy.
up. Thank you, Nancy. And yes, there is a place for everything, and all of it is complementary to each other. And when I do presentations on dementia, I'm always talking about the importance of support group. Yes, it's good to have intellectual knowledge from research. Yes, it's good to go to professionals. Yes, it's good to have medication, but there is nothing like having someone walk alongside you that has been in your shoes going through dementia as a caregiver, anxiety, depression. There's nothing about that peer support. But thank you so much for bringing that up. Very, very important.
And we have started a little pilot project. We did the first one this week, where we're going to add a half an hour on to Lucy Barilek's sessions that will be a support group for those that would like to continue on after she does her presentation and talk about things that relate to them individually. And so it's even going to be available here. We're trying it out, and we may expand it if things go well, which they did this week. I was very encouraged by it. Well, I want to thank
that.
you.
That's great.
Yeah, and it just, everybody was real open. We stopped the recording, and so you aren't being recorded anymore, and you can just feel free to say whatever. So look for that in Lucy's next sessions coming out. Natalie, as always, thank you so much for being with us today.
Thank you. Thank you for having me.
Yeah, I do so love working with you. Carol, thank you for sharing information with us, and hopefully some people will decide that they want to help and participate in your research. I think it's a really wonderful idea. Thank you so much for being with us today, and I hope to see you next time on the Caregiver Teleconnection. And be safe, and in my area, stay warm today. So see you soon.
Bye-bye.
Bye-bye.